Now we look at the second part of the lecture, which is neurodegenerative diseases. These are a group of diseases that are characterized by the progressive loss of particular groups of neurons in the gray matter with associated changes in the white matter. Secondly, the selective pattern of neuronal loss, whereby it affects one or more group of neurons while leaving the others. And thirdly, the accumulation of protein aggregates which are resistant to degradation. Degenerative disease tend to involve particular neural systems and have relatively similar presenting signs and symptoms. For example, if they affect the cerebral cortex, the patient will present with dementia and progressive loss of cognitive function. If it affects the basal ganglia and brainstem, there will be movement disorder, rigidity, and abnormal posture. If it affects spinocerebellum, there will be ataxia and spasticity. And if it affects motor neurons, there will be hyperreflexia, spasticity, and extensor plantar response. Examples of degenerative disease that affects cerebral cortex is Alzheimer's disease. If it affects the basal ganglia and brainstem, examples are Parkinsonism and Parkinson's disease. Friedreich ataxia are examples of spinocerebellum degenerative disease, and amyotrophic lateral sclerosis if it affects the motor neurons. This table shows proteins that are accumulating in degenerative disease. The protein aggregates are resistant to degradation and show aberrant localization within the neurons. For example, you see A beta is accumulating in Alzheimer's disease, as is tau protein, Alzheimer's disease and Parkinson's disease, and TPD43 accumulates in amyotrophic lateral sclerosis. Their formation appears to be an adaptive response that enables cells to sequester smaller aggregates of the same protein, which are directly toxic to the neurons. However, as more and more protein is shunted into the aggregates, the normal function of the protein may also be lost, and that can cause cell injury. The principal clinical manifestation of degenerative diseases affecting the cerebral cortex is dementia. It is a syndrome that leads to deterioration in cognitive function beyond what might be expected from the usual consequences of aging. It affects memory, thinking, orientation, comprehension, calculation, learning capacity, language, and judgment. However, consciousness is not affected. The impairment in cognitive function is commonly accompanied and occasionally preceded by changes in mood, emotional control, behavior, and motivation. This table shows the possible causes of dementia, and degenerative disease are only one of the possible causes. Now we look at Alzheimer's disease, which is the most common cause of dementia in elderly. It affects 40 million people worldwide, and the estimated 50,000 people with Alzheimer's disease in Malaysia. Clinically, there is impairment of higher intellectual function with alterations of mood and behavior, and there is progressive disorientation, memory loss, and aphasia. After 5 to 10 years, patient becomes disabled, mute, and immobile. The fundamental abnormality in Alzheimer's is the accumulation of two proteins, A beta and tau protein, in specific brain regions, likely as a result of excessive production and defective removal. The two pathologic hallmarks of Alzheimer's are amyloid plaques and neurofibrillary tangles. Plaques are deposits of aggregated A beta peptides, and tangles are aggregates of microtubule binding protein tau. Both plaques and tangles appear to contribute to neural dysfunction. This picture shows protein aggregation in Alzheimer's disease. The first part is in a normal person, where amyloid precursor protein cleavage is done by alpha and gamma secretase, and this produces a harmless soluble peptide. In Alzheimer's disease, there is cleavage of the amyloid precursor protein by beta and gamma secretase, which forms the A-beta peptide, and this can accumulate and aggregate to form the plaques, and also it contributes to the formation of tau phosphorylation and the neurofibrillary tangles. It also contributes to neuronal damage. Tau protein is a microtubule-associated protein, and in Alzheimer, the tau becomes hyperphosphorylated and loses the ability to bind microtubules and forms neurofibrillary tangles. How the tangles injure the neurons remains poorly understood. There are genetics and environmental risk factors for Alzheimer. A person with first-degree relative with Alzheimer has double the lifetime risk to get the disease. Age is the main risk factor for Alzheimer, as incidence increases exponentially with age. Head trauma and vascular risk factors also increase Alzheimer's risk. Epidemiological studies show that taking anti-inflammatory drugs confers some protection against the disease. The gross feature of the brain, comparing the normal brain with Alzheimer's. The brain with Alzheimer's will have atrophy of the cerebral cortex compared to the normal brain. There's also widening of the sulcus. See, the sulcus here is wider compared to the normal one. So the sulcus here is wider compared to normal brain, and the narrowing of the gyrus. So this is one gyrus is narrowed here, compare here to here. As we mentioned before, the two pathologic hallmarks of Alzheimer are amyloid neuritic plaques and neurofibrillary tangles. Neuritic plaques are deposits of aggregated A-beta peptides. You can see the plaques here, and here, here, with dystrophic neurites surrounding the amyloid core. And you see the neurites with the core that are immunoreactive for A-beta. The second pathologic hallmarks of Alzheimer is neurofibrillary tangles. The tangles are aggregates of protein tau. The tangles are within the cytoplasm of the neuron. You can see here, displacing the nucleus. The nucleus is at one side here, displaced. So this is highlighted by the silver stain. So you see the tangles with the displaced nucleus. A few gene mutation that is associated with early onset Alzheimer's disease, such as the APP gene mutation, which is located on chromosome 21, and this is associated with Down syndrome. Individuals with Down syndrome can develop early onset Alzheimer. Other genes that is involved are chromosome 14 and chromosome 1, which is also associated with early onset Alzheimer. The diagnosis of dementia and Alzheimer requires clinical history and examination, and you can do a few investigations, blood tests to exclude the other causes of dementia, imaging to visualize the cortical atrophy, and you can do other tests such as CSF for tau and A-beta measurement and genetic studies. Briefly on the treatment of Alzheimer, there are some drugs that stop the breakdown of acetylcholine, which is important for memory and learning. And drugs such as donepezil can slow down the symptoms from getting worse in half of the people. They work by inhibiting the CNS acetylcholinesterase, thus increasing the brain acetylcholine level. Aducanumab is also a human monoclonal antibody that is being studied that targets aggregated forms of beta amyloid.